Thank you very much for being invited in this wonderful conference. And I really thank you, the organizing committee, for this wonderful organization and efforts made to secure the well done undergoing of this conference. My topic for today is airway and ventilation management in pediatric neurosurgical cases. I am Professor Erdin Dome from Faculty of Medicine, University of Medicine in Tirana, in Albania. So the conflict of interest are with thermofish Brahms procalcitonin measurement, but the topic for today has nothing to do with this kind of my studies, let's say, financially supported by Thermo Fisher Brahms. So airway and pediatric neurosurgery, there are two big problems. There are pediatric patient and neurosurgical patient, and of course, the airway and ventilation in this patient are very challenged to every anesthesiologist, and of course to pediatric neurosurgery anesthesia team as well. These are let's say views or photos from my practice in my institute. This is a very original article, very good article published in 2022 that mentioned that anesthesiologists should be aware of unique challenges of anesthesia management in pediatric neurosurgery patients, such as, for example, difficulty in positions of the patient during surgery, during operation, or difficult airway and abdominal skull shape, for example, in hydrocephalus, sudden and massive blood loss, venous airway embolism, apnea, air obstruction, and ocular injuries that can often see in prone position surgery. Why so special pediatric airway in neurosurgery? This is a wonderful article published in 2020 in Indian Journal of Neurosurgery, Anesthesia Consideration in Pediatric Neurosurgical Patients. This article mentioned all the things that probably pediatric anesthesiologist knows, like, for example, decreased physiological reserve, standard pediatric airway features that are common for pediatric anesthesiologists. In neurosurgery, probably the patient are with altered conscience. The duration of surgery is longer than the other surgeries. Type of surgery, for example, the surgery that can cause a damage on mixed cranial nerves, positioning effects on the respiration, effects on airway, manipulation of let's say intracranial pressure or already increased intracranial pressure, and of course immaturity of these patients. Neurosurgical pediatric patients have some features, for example, like intracranial bleeding. During airway management, we can let's say further increased intracranial pressure. We must avoid hyperventilation or apnea during airway management because not only due to deceleration, but of course with taking in consideration the effect, the vasodilatory cerebral vascular effect of hypercapnia. But of course, positioning consequences possible in spinal cord injury, the presence of C-color in spine at risk of instability can make us managing the area more difficult than in a usual situation. Full stomach and concerns regarding extubation, and of course the need for postoperative, let's say, intubation in an unstable patient, requiring, for example, another surgery, or need to maintain in prone position, like in meningomyelocele or specific teratomas. These views are from my patient in my institute. Original pediatric patient undergoing for tumor resection in neurosurgery. Pediatric airway features, as everybody knows in pediatric anesthesiology, are to do with let's say with the form of larynx, like funnel shape, and the nerve spot at the level of cricoid, life-threatening subglottic obstruction secondary to mucosal swelling. Children may be faster hypoxic due to increased metabolism, or large tongue or large head, like in hydrocephalus. Head deflection must be associated with tube dislocation. And of course, positioning of pediatric neurosurgical patient is risk factor lag in prone position due to decreased capacitance or compliance, pulmonary compliance. In sitting position, decrease or let's say compromised hemodynamic, or more often is face, let's say, venous area embolism, and head dressing by the surgeon, because we are not able to manipulate the patient airway so faster and so quickly if the patient, if the head, let's say, is the prone of the neurosurgeons. Another feature in pediatric anesthesiology, neurosurgical anesthesia, is the fact that, as we know, in newborn, let's say the anthropometric measurements, or the measurements are far more than adult. For example, the head in adults is proportionally not so bigger than in a newborn. So a newborn has small body but large head, and let's say this is normally, but you can say hydrocephalus. So the head can be more larger than, let's say, a normal head in a normal pediatric patient. There are several pediatric hypoxia causes, like, for example, hypoxia causes bradycardia. Bradycardia can cause further hypotension that can worsen hypoxia. The presence of secretion, area irritability, increased risk for laryngospasm, for airway edema. The patient children are uncooperative to the anesthesia team, and of course some specific features regarding apnea of prematurity that can be faced as altered ventilatory responses to hypoxia, to hypercarbia, to sleep, and so far. As you know, if we are managing pediatric airway, the first attempt is the best one, and if it's not done correctly, 1 millimeter of circumflex edema in infants can have severe consequences, like, for example, reduced by 70%, 75% of cross-sectional area, and increased by 16 folds of resistance. That is not so common in adult patient. This article, published in Current Opinion of Anesthesiology in 2014, Anesthesia for Intracranial Surgery in Infants and Children, faced us or tells us some more frequent complications that or coexisting conditions that can impact anesthetic management. As you see in yellow color, they are mainly directed to airway management, to ventilation, to extubation. For example, like hypoxia, postoperative apnea, aspiration pneumonia, laryngospasm, bronchospasm, difficult tracheal intubation, hyperkalemia after succinylcholine, resistance to non-depolarizing muscle relaxants, or in neuromuscular disease, for example, postoperative respiratory failure, in cardiac malformation complications like apnea and aspiration pneumonia, and so far. So airway are very important, not even in pediatric patient, but especially in pediatric neurosurgical patient. And you know the code formula, for example, that is internal tube diameter in millimeters is equal to 16 plus h in years, divided in 4, but we can take present the children airways features We can choose during the airway manipulation the correct size of tube, and of course we must be assured for the correct position of the tube depending on the position. So we have to ensure the tube in the moment after the intubation. But of course, for every position difference in pediatric patient, we can see the tube and how the patient is ventilated after the new position. Regarding induction, sorry, we may have in neurosurgical patients. This is a wonderful article, Anesthesia for Neurosurgical Procedures in Pediatric Patient, published in Indian Journal of Anesthesiology in 2012, that we may have a mentally stable and patient with mentally compromised, so with decreased conscience. In this patient, we can phase or we can manage the airway using rapid induction. Salic with rapid induction is the preferred to minimize expiration. After several in normal patient with not so compromised conscience, we can use self-run, and after that we can put or we can insert an intravenous cannula. And if intravenous cannula is stabilized in a ward, we can use, for example, normal IV induction. Regarding the central lines, we preferred femoral route for central lines, probably because the internal jugular can reduce the venous blood to come back to the heart and can increase the cerebral edema. And for example, seated position, this is not suitable like in adults to air aspirate if venous airway embolism occur. But femoral route is more preferred. Of course, we have to take care about so to proceed with the patient, to proceed with the procedure, in a very aseptic, strictly aseptic manner, in order to prevent all let's say the increased risk, hypothetically increased risk of bloodstream infections from femoral route as used for the central line, let's say, proposes. This article, published in British Journal of Anesthesiology, Pediatric Neuroanesthesia, it's a very sympathetic paper that can explain to us in awake IV placement and inhalation induction. Awake IV placement, for example, is reserved in older patient cooperative with elevated cooperative patient with elevated intracranial pressure and poor baseline neurologic functions. But inhalation induction can be reserved, can be used in younger patient, in anxious or uncooperative patient with normal intracranial pressure, with good baseline neurologic function, and of course unsecured aneurysm. Pediatric perioperative management. Perioperative pediatric management in pediatric neurosurgery is a review article by these authors that you can see in slide. And let's say that the flow chart for rapid sequence intubation in patient with high intracranial pressure, it's not so different like in adults. But of course, there are some physiological effects on patient positioning that we can face in neurosurgery. For example, if the pediatric patient is operating by a tumor in the posterior fossa crani, the patient, according to the neurosurgeon's preference, may be sitting position or may be in prone position. In sitting position, we can have enhanced cerebral venous drainage, decreased cerebral blood flow, so we have to increase a little bit the pressure. We may have postural hypotension, but in prone position we can face the venous congestion of face, tongue, and oral mucosa, and decreased lung compliance and venocaval compression from abdominal compression. So in this slide, we can explain very good all the different things in sitting position and in prone position. In sitting position, for example, the ventilation may be better, but as a proposition, but we face another problem, we face hemodynamical problem in sitting position. So the transducer of arterial line for invasive blood monitoring bit to bit must be positioning in external malleus level in order to ensure that blood pressure is adequate for brain adequate brain blood flow in order to ensure a good brain perfusion during the surgery. Another problem that is often explained in the literature, for example, from this beautiful chapter by Soriano in pediatric neuroanesthesia and critical care, that you can see that the tube in normal, in normal position, and the tube during deflection can go deeper, and probably can we may have let's say selected bronchial intubation, and during extension the tube has a tendency to go out. So we must be very careful during the positioning the pediatric neurosurgical patient, because slightly movement of the head can cause tube, endotracheal tube moving forward or moving or go out, so dislocation of endotracheal tube. In specific situations, like for example in hydrocephalus, we had a large head, so difficulty to intubate the patient at that level of conscience due to hydrocephalus, long duration if shunts or difficult shunts are clarified, not acceptable airway and tube, because the head belongs, let's say, to the neurosurgeons, and rotation of head and tube dislocation may be often occur. In Upper Croson syndromes, for example, had maxillary hypoplasia, prognatism, and hydrocephalus, and hydrocephalus. Upper syndrome had macroglosia, sleep apnea, tracheal cartilage sleeve. Temporomandibular joint stiffness is often faced, and in coronary synostosis, due to the large head, we may have difficult airway management. In this beautiful article in Current Anesthesiology Reports of 2022 in coronary synostosis, pediatric anesthesia, a review of the recent literature, reduced temporomandibular joint movements, fused cervical spines, or facial abnormalities may lead to difficult airway management in the patient suffering and undergoing from synostosis repair. These are original photos from my work. This is a patient in sitting position in posterior cranial fossa surgery. The anesthesia team must have in attention the dislocation of the tube by movements by the surgeon, interoperative patient movements by the surgeon as well, and circuits weight on tube. So we must secure not only the tube but the circuits not to have such a heavy weight. And to be the reason for the tube dislocation during the surgery. This is another patient, 1 year old patient with a tumor resection in prone position. The patient may have possible significant facial and tongue edema, so the extubation may be problematic in this patient, and we must ensure that thoracic and pulmonary compliance are okay, so the patient is ventilating okay, maintaining an homeostasis of CO2 and O2 and pH in order to guarantee a smooth and a normal anesthesia practice and a smooth neurosurgical procedure. So decreased thoracic and pulmonary compliance are more often faced or occur more often in prone position. Carrier malformation. The slides, so the views are original from my institution. So regarding carrier malformation, carrier 2 malformation, for example, it's a very challenging situation, which may lead to compression of cervical cord and brainstem during manipulation of secure airway associated with bradycardia, with hypertension, with hypertension, but also with difficulties of extubation in the postoperative period. Another hot point on pediatric neurosurgery is extubation. The pediatric neurosurgical patient. So extubation of the pediatric neurosurgical patient, it's not like only pediatric patient, but of course, regarding recovery from anesthesia, we tend to rapid awakening the patient in order to early neurological assessment. Minimal coughing and strain in the endotracheal tube must be avoided. And of course, trachea is extubated once the child responds to commands or events open their eyes. There are top 5 predictors of successful extubation, like conjugate gaze, eye opening, facial grimace, proposed movement, and spontaneous tidal volume over 5 ml per kilos. But of course, maybe a situation with prolonged recovery from anesthesia, like in the patient of brainstem surgery, producing apnea or vocal cord paralysis, or presence of airway edema and postoperative obstruction due to prone position, large lingual or supraglottic swelling due to prone position, significant blood losses, for example, in cardiac anastosis, and of course, the presence